Health and Wellbeing Queensland acknowledges the Yagara and Turrbal people, the traditional custodians on the lands on which this podcast was recorded, and the traditional custodians on the lands and waters on which you are listening. We pay our respects to the Aboriginal and Torres Strait Islander elders past and present, for they hold the memories of the traditions, cultures and aspirations of Australia's First Nations people.
Often, especially in the public system, you'll be meeting that person for the first time when they're in labour. So I think always giving the perception that you have time and patience and are willing to listen is really important.
Hi, I'm Dr. Sam Manger, a GP and your host of this series, The Clinician's Guide to the First 2,000 Days, brought to you by the Queensland Government through Health and Wellbeing Queensland. Prevention across the first 2,000 days offers an opportunity for healthcare professionals to support generational health improvements. But preventative health will only be successful if it is done with confidence and empathy and an evidence base. Over the course of this series, I will be talking to some of Queensland's leading experts to explore how they discuss preventative health and how to create meaningful change for the next generation. Let's get started. Our second podcast of this series is going to deep dive into the medical side of antenatal care. And to do so, I have Dr. Kirstin Millard and Kieran Froese joining me today. Kirstin is an obstetrician and gynaecologist with a Masters of Reproductive Medicine. Kieran is an endorsed clinical midwife and has been a midwife for almost 20 years. Both Kirstin and Kieran work at Mater Mothers in South Brisbane and at Hatch. Thank you so much for joining me, Kirstin and Kieran.
Thank you.
Thanks for having us.
Kirstin, let's start with a sort of broad overview question. How has pregnancy care changed over the last 10 to 20 years since you first started working in this field?
There's been lots of really exciting changes, I think, in the pregnancy care space. A lot around new technologies in medical things and also in what we know about diseases. So a lot in the maternal fetal medicine space. We've got new testing for chromosomal abnormalities with the NIPT tests, which allows more accurate screening. We've got better ultrasound machines, so our ability to diagnose abnormalities earlier. We know a lot more about preterm birth and risk factors for that and now have treatments for it. We know more about preeclampsia and we've got better risk factor screening for that and potential preventions available too. So that's, for me, it's really exciting. We're much better at looking after really small babies. And so now some babies will survive if they're born from 23 weeks onwards. So that's big changes.
Yeah, that's fantastic. So definitely some improvements in both screening, diagnosis and management sort of across the board by the sounds of it. Kieran, have you seen a lot of changes over your 10, 20 years?
Yeah, I think there's been a real improvement in accessibility to different models of care and particularly midwifery-led models of care. So we've seen since probably 2011, the Mango trial, we've seen midwifery-led continuity models really open up and seen really improved outcomes across all risk groups.
And has the role of a doctor or midwife changed in that time?
Midwifery has changed somewhat in that we've seen the development of endorsed midwives. So we've got midwives who are able to operate more autonomously and provide independent care to people.
I'd say it's definitely become more collaborative.
Definitely more collaborative, I would agree.
And the playing field is much more level.
Yeah, and that's really where we're going to see the best outcomes, isn't it, when we're working together and we've got different roles that complement each other.
Yeah, absolutely. No, the blended approach is the best approach. And so, Kieran, is there a certain number of appointments or checks a woman would expect as part of routine antenatal care?
Yeah, in the public system across Queensland, our schedule of visits is informed by UK guidelines, the NICE guidelines. And so that sort of lays out a schedule of expected visits. In some high-risk groups, you might see more regular appointments, and often then in private care you might have more appointments as well and more individualised care to what people need.
And would you say there's a sort of average? Because you can be guided somewhat by the various sort of books out there and guidelines, but it seems to be that the closer you get to due date, the more frequent you get reviewed.
Absolutely. So most people in a public system, which is a more standardised system, would expect to have visits at 24, 28, 32, 34, 36, 38, 40 weeks. And like I said, in a private system, you can probably expect a few more visits earlier in pregnancy. and also later in pregnancy when you might go down to weekly visits. So you're just having much more contact with your care providers.
Which makes sense. Does that differ across Queensland or in other services? So do we see the recommendations are still the same regardless of geographic region?
Regardless of geographic region, it's all the same. But like I said, there's higher risk models of care or people with more risks in their pregnancy, and they can expect to be having more contact with their healthcare providers through their pregnancy.
And so, Kirstin, let's jump into starting at the beginning, so the first trimester, and this is obviously a very important part of antenatal care. If a woman sometimes may miss this because she may not be aware that she's pregnant, and so can we start with what's included in first trimester tests and then what to do if someone misses these early screening tests?
The first test every woman needs is a set of blood tests, which includes full blood count, group and hold, HIV, syphilis, rubella, hepatitis B, C. Some women will need thyroid function tested, and some women with the risk factors for gestational diabetes should have an HbA1c tested as well. Women should have a viability scan and then a dating scan between 7 to 11 weeks. And then many women also choose to have an early anatomy scan around 13 weeks. If women choose to have aneuploidy screening, this can be done either at an 11 to 13 week scan with the HCG Pap blood test, or they can choose to have the NIPT blood test from 10 weeks gestation.
Let's break that down a little bit more detail. So you mentioned there a viability scan, a dating scan, and an anatomical scan as options, so to speak, for that period. So that's quite a number of scans. Does the government pay for that, or does the patient pay for that? That can often be a deciding feature if ultrasounds are expensive. What's the pros and cons of each of those? So the dating scan is obvious. That's to see if it's intrauterine and what your sort of estimated date of conception is, and delivery. And the anatomical scan, what does that sort of look at? So
the early anatomy scan is growing in popularity because people are now having non-invasive prenatal testing, which is a blood test. That doesn't allow for a view of the baby earlier on. So with the improvement in ultrasound technology, we can now actually see the structures of the baby reasonably well at 13 weeks. It doesn't replace the later scan, but if a baby has a significant heart defect or has severe spina bifida, this can be detected on this early scan. And this gives women a chance for earlier counselling and potentially earlier action rather than waiting to find out about this at 19 weeks.
And so you mentioned the NIPT there, which is a maternal blood test, picking up a little bit of baby DNA and looking at that. And it seems within that there are multiple levels of intensity that you can do within that. Could you give us a little brief overview as to that?
So the NIPT test is most accurate for 3 major trisomies, so 21, 13 and 18, and is reasonably accurate for sex chromosome abnormalities. Its accuracy does decline when you test for more things, so that has to be conveyed to patients before you use this test. In all the results you get, though it is quite accurate for Down syndrome and the other trisomies, it's still a screening test, and you would recommend a diagnostic test such as amniocentesis if you're going to change your plan for the future of the pregnancy. Another technology that's coming soon is checking the blood group of the baby with NIPT, and that is very accurate though.
With the NIPT, it sounds like there's a number of tests in the sense of there's the basic screen sort of component, as you see, the three trisomies plus or minus sex chromosomes, and then you've got other layers that a woman can decide based on, as you say, cost, based on what they're actually going to find out, and then, as you say, informed consent around, okay, well, if we get a positive screening test, then these are the options from here, like an amniocentesis for a diagnostic. So there's a whole conversation that goes in around that. Are there any good resources that you will often use or can weigh these things up in a helpful way?
Most of the labs that perform these tests have quite good resources attached to them. We commonly use VCGS, and on the back of their pathology form is an A4 sheet which gives information for the patient.
And VCGS stands for?
Victorian Clinical Genetics Services.
Okay, very good. Thank you very much. And then as we progress through the pregnancy, so we're going up to the sort of 18, 20-week mark now, what are the routine tests that are recommended throughout the rest of the pregnancy?
So The next test that people need is their morphology scan, and that can be done between 19 and 23 weeks. It's generally done a little later if you've had an early anatomy scan, or a little earlier if you haven't.
Again, that's looking for anatomy and various other things. And then throughout the rest of the pregnancy, we've got the 28-week check and so on. So what are those sort of screening tests that we do from a medical point of view?
Between 24 and 28 weeks, women should have a full blood count, group and hold, and a glucose tolerance test and syphilis screening. The final prescribed set of blood tests is between 34 and 36 weeks, which is a full blood count, group and hold.
Full blood count and another syphilis screen.
And another, thank you.
So syphilis is now recommended to be screened 3 times in all pregnancies.
Wow, that's quite a change. So is that because we're seeing an increase in rate of syphilis?
We're seeing a rapid increase in syphilis in all populations. So it's now universally recommended that everybody has 3 syphilis screens during pregnancy. And anybody that hasn't had a 36-week syphilis screen should theoretically have that screening done when they're giving birth because of the risk to the baby.
So we're seeing an increased rate. That's worrying. And is there any role for swabs or, group B strep and all those things?
Women will be swabbed at 36 weeks for group B streptococcus. In Queensland, we take a risk factor based approach. So if you've had a baby that's been affected by GBS, or you have prolonged rupture of membranes, or you develop a fever in labour, then you would be treated with antibiotics because your risk of GBS is higher. If you have a swab and GBS is detected for some other reason, so either on a swab or you had a urine test during the pregnancy which showed GBS, then you would be treated during labour.
Again, that highlights the importance of the urine MCS being done as part of that sort of early first trimester screen.
That's right.
And some of the common symptoms that will happen in that first trimester. So you'll often see a variety of symptoms, but hyperemesis being pretty common. Kieran, this must be something that you deal with a fair bit, and Kirstin as well. So what are the common approaches to assessing and treating these sorts of common symptoms?
So I'd say nausea and vomiting in pregnancy is very common for a lot of people, particularly in that first trimester. And for most people, that eases off after the first trimester. Some people have a more severe form of nausea and vomiting called hyperemesis, and that may continue all the way through the pregnancy. For the majority of people, it can be managed with simple medication, so antiemetic medication. There's different combinations of medication that people can find effective, as well as, to some extent, lifestyle type factors. Like, people often find it helpful to have something in their tummy, so not feel empty, and usually things like dry crackers, dry toast, low flavour foods can be helpful for that, as well as getting enough rest.
Kirstin, do you want to add anything to that? What are the medications that we were referring to, the antiemetics?
There's a variety of medications, and there is a good SOMANS guideline. Society of Obstetric Medicine for Australia and New Zealand, they have a really good guideline on hyperemesis. So it's a graded step up. One of the common ones people use is doxalamine or Restovit as a first line. Pyridoxine, ginger can be helpful. Maxilon Stemetil can be useful too. Ondansetron should be used sparingly because it can cause constipation, which can then make your nausea worse, but is sometimes the only thing that people find effective. Sometimes people need to come into hospital, sometimes just for some rehydration, but sometimes need a several-day stay. Sometimes people need steroids as well, but that would certainly be in the context of having seen an obstetrician and in hospital.
And very severe illness. So here's the opportunity for you both to sort of add in any sort of pearls of wisdom that I'm sure you have when it comes to common challenges that a woman may experience as they progress in their pregnancy from a sort of, inverted commas, normal pregnancy point of view, and how we can, if there are any tips or tricks that can help women in that regard.
I think just general discomfort is common as pregnancy progresses. In early pregnancy, you tend to see more of the nausea and vomiting of pregnancy, and then you often get a bit of an easier period through the second trimester when symptoms are easing off, but the discomfort hasn't become quite so prominent. And then as you get into third trimester and your belly's growing really big and the effects of the hormones of pregnancy are making your joints more relaxed, you can start to get more discomfort in your hips and back, more trouble with sleeping, finding comfortable positions. We recommend women sleep on their side in pregnancy, especially from 28 weeks onwards. And so people can sometimes feel quite limited in the number of sleeping positions that they have, as well as being interrupted to go to the bathroom many times through the night and have some trouble getting back to sleep sometimes when they're feeling very alert.
Fatigue can be a big problem for women, and both from sleeping and iron deficiency is pretty common as well.
So it's an interesting point because we don't test for iron routinely. Your iron deficiency you're picking up through obviously hemoglobin if they've actually become anemic, but otherwise we're not actually screening for it. So are we just picking up if a woman becomes more fatigued to a point where we actually will investigate it then, and or the hemoglobin drops, and or we actually think that there's a high risk, say, for nutritional deficiencies from whatever reason. These are the reasons we might actually look into iron.
That's correct. I've got a pretty low threshold for checking for iron. So anyone who's had a history of iron deficiency, anyone who has hyperemesis, I would routinely check them. If they're tired, I would check it.
Yeah, fair enough, because that seems to me the case as well for some GPs, fairly low threshold for checking that iron, as you say, based on past medical history, symptoms, and obviously contextual factors like hyperemesis, less intake would make sense. And that baby is obviously utilising a lot of those nutrients to grow, so mum's taking second best there. And so we've talked about a number of things here very usefully in the sense of screening tests throughout pregnancies, and we've mentioned a number of really good guidelines and resources around that. For advice for health professionals to look at sort of across the pregnancy, what are the main go-to resources that might be available, say, from Queensland Health or other national resources that you would just commonly recommend or use?
The Queensland clinical guidelines should probably be the first go-to for most things. I also find the Australian-New Zealand food safety standards really helpful in terms of advising people about dietary recommendations and cautions to take during pregnancy. There's a few dietary, not restrictions, but areas where people need to be more cautious during pregnancy.
So let's talk now about the actual model of care. And we know the importance of continuity of care during pregnancy. And so, Kieran, what are the benefits and challenges of different models of maternity care? As we said, we've seen that change a little bit over the last 10 to 20 years, midwife-led care, GP shared care, private obstetric care. So there's a raft of different options that a woman can go into. What are the benefits and challenges of that, and how do we advise around that?
We've really learnt a lot more in recent years about the benefits of continuity of care in pregnancy, and that's really changed the landscape for maternity care across all models, trying to look at improving continuity, whether that's continuity of specific care or continuity of philosophy of care as well. In terms of midwifery, there's been a lot of evidence in the last 10 to 20 years supporting midwifery continuity, including lower rates of preterm birth, lower rates of intervention during birth, improved breastfeeding rates for breastfeeding initiation and continuation. So there's a lot of evidence to support midwifery continuity. To an extent, some of those benefits extend to other forms of continuity. And what we see often with GPs is that is a family doctor who is able to provide continuity over a much broader spectrum of the family's life. And this is a time when a lot of people are starting to access healthcare far more regularly than they may have previously. So it's a good time to get in touch with the community, understand who your local doctor is and who you're going to be seeing through your pregnancy. And it's also really important for GPs, often as the primary contact and the referring point, to know what's available in terms of models of care so that they can refer women appropriately into a model that they want to have.
Yeah, that's a key point around becoming aware of what is available to us, whether it's, as you say, midwife-led services that may be local, private, or connected to the hospital in some respect, and or obviously private obstetricians. I think most GPs would be aware of that pathway, but probably less aware of their sort of midwifery options locally. I'm curious about the rural and remote context of this and how models of care have changed for people who have traditionally that much more difficult geographical access to care.
Absolutely.
And has telehealth changed that, or how are we managing and how are we supporting people in those regions?
Yeah, telehealth has really changed the landscape of healthcare and how accessible different models of healthcare can be to people all over the state, but particularly in those regional and remote areas. So whether that's being able to have specialist appointments via telehealth without travelling, or even just having consultation during pregnancy, it can add more accessibility to more models. I'm also conscious that across the regions of the state, we've seen closures of private services, and that limits accessibility for some people to models of care that they can have for their birth as well. So requiring people to either travel long distances or to limit their options.
Kirstin, have you seen this too, being an obstetrician in the hospital sector, where you've seen more people, they're being referred in, but that you're doing more telehealth or you're doing more sort of remote care? Is this becoming more common and more reliable, or is it still very much in person is gold?
Most people, if they live locally, would be seen in person, certainly in the private system. Publicly, Mater Hospital uses a lot of telehealth to link in sort of with their satellite hub, so women will come to Inala or Coorparoo or out at Springfield and be seen by a midwife there and link in via telehealth to the obstetrician at South Brisbane. So It's been utilising every day, really.
Yeah, I think in some of the bigger metro centres, the use of telehealth has seen reduction in waiting times for women, because those appointments can be more seamlessly back-to-back without having to wait in a waiting room, find parking at a hospital and travel. So it's increased efficiency.
Don't go anywhere. Our conversation continues after these messages.
Rising rates of chronic disease are one of our greatest public health challenges. 2 in 3 adults and 1 in 4 children live with overweight or obesity. We need to shift the dial. That's why Health and Wellbeing Queensland has created the Clinicians Hub. Designed for health professionals to support preventative health, Clinicians Hub is a digital ecosystem of initiatives, resources and tools, such as podcasts. It supports clinicians with referral pathways, models of care, education opportunities and more. Find out how Clinicians Hub can help you at hw.qld.gov.au/hub.
And now, back to the conversation. And so now let's get into the conversation around birth plans, around, how do we open up that conversation? When should we start having that conversation? And what are the nuances of that conversation? So Kieran, I'll throw to you on this one first.
I think birth plans have become a bit of a hot topic, and at times they're viewed quite controversially, depending on who you speak to. One of the outcomes of the New South Wales inquiry into birth trauma found that we really need to be paying more attention to birth plan and centering women's wishes in the care that we provide. I'm really fond of birth plans. I think it's a great opportunity for us to keep a woman or her family's values at the centre of the care we provide, and it's really difficult for us to keep her values at the centre of our care if we don't know what those values are. So I believe that everybody has a birth plan, whether that is just going home with a healthy baby or whether that's more detailed about how you want certain procedures to be offered to you during your care. So I think softening our views and making people feel really welcome to voice what's important to them forms the basis for having a healthy culture around birth plans.
And do you recommend starting that conversation, in the first trimester, or you think as things progress around the sort of 20-week mark, it's when let's start talking about this in a bit more formal of a way? And are there guidelines or resources or checklists in a way that can help guide this conversation?
I don't usually get too deeply into birth plans right from the outset, although I might be feeling around to see if people are coming into the pregnancy with really set ideas. Most people have a really flexible view of their birth plan, and we know that most people come to this with flexibility. It's a little bit like if you're planning an international holiday, you will make plans. You don't just arrive in the airport in LA and see what happens. You make plans around what you want to do and how you want to have the best of your trip, but you accept that things may change, flights might be cancelled, weather may interrupt things. So it's really similar with birth plans. Most people accept that there's a lot of elements that might be out of our control. But it's really important if we can identify early the people that have less flexibility in their birth plan, so that we can put some specialist work into understanding what care they're willing to accept, what interventions they may be willing to accept, and how we might navigate complications if they come up. I find for most people, really starting to get into the workings of a birth plan probably happens over about 30 weeks, where the birth is becoming a little bit more imminent and prominent in the thoughts, and it gives us a good opportunity by that stage to really understand what external factors might be influencing plans around birth as well. And then giving us enough time to look at putting some education and planning in to help people achieve the birth of their dreams.
The birth planning or mapping is probably the word that I think I like to use better. It's an evolving conversation that you have throughout the course of the pregnancy, and it's definitely an easier conversation to have when you have a continuity of care model, but can still to some extent be done in other antenatal settings as well.
There are plenty of resources. So if you look online, there'll be templates and checklists that you can fill out. What we often see when people come in with these sort of templated birth plans is often they come from an American perspective, not from an Australian perspective, and 90% or more of those birth plans are routine care for us. So sometimes you may have several pages of wishes, which is just routine, which is why it's really good to have a conversation about this stuff before sort of landing in birth suite, because you can sometimes streamline those wishes and desires and bring it back to sort of the core values.
Yeah, in GP training, and I'm not familiar with the other specialties, but we often talk about the ICE acronym, which is Ideas, Concerns and Expectations. And that seems like a good place to start with this sort of birth mapping or birth plans. What are the ideas around this? What are your concerns? And what are your expectations? And that can then lead into, and then what happens if, you know, yes, that plan A, but what happens if X happens? Then what are your ideas, concerns, expectations around that? Because as you say, some women won't want certain types of interventions at that stage. They may change their mind, obviously, but it's really important to open that up at very least. Now, one thing we are seeing, and I live in this, I work in the Sunshine Coast hinterland, so we're seeing it around the place, is the increasing rise of home birth requests and other professionals to the birth, such as doulas. So is this a trend that we're truly seeing in sense of an increase in home births? And what's the best way to approach this?
I think there does seem to be a trend towards people opting for care potentially outside of recommended guidelines, of which I want to say home birth, when done safely, is not outside of recommended guidelines. It's considered very safe in the right setting. Once you're getting into doulas and free birth, it may be moving away from that clinical safety. And maintaining safety in these cases is really about keeping the dialogue open. So having really smooth referral pathways and transfer pathways so that if things aren't feeling safe or aren't going to plan in a home situation, that there's a very easy transition into hospital that doesn't feel like a failure of the birth for the woman or for the care providers, and that the care providers in the hospital can also welcome that woman in with open minds to help still provide her with a birth that feels safe and satisfying for her. And when I speak about safety, there's obviously clinical safety, but I think emotional safety needs to be considered in that as well.
Definitely. This is something you must be presented with, Kirstin?
Yes. Look, can be very challenging situations when these women come to hospital, and I think the importance is openness, understanding of what their specific needs are, being non-judgmental, and remembering that we're there for the best outcomes for mums and babies.
Having that conversation throughout pregnancy about what the birth plans are, what the intentions and, as we say, ideas, concerns, expectations are. If a home birth is a part of that, then make sure that conversation is fully had, and you can, as you say, safety plan / harm minimize as best as possible, and make it transparent to the rest of the team. So the hospital ideally knows that this woman's doing a home birth and this is going to be around this time, and just in case something goes not to plan, then just be aware. And so it's not at the last moment sort of raised.
It's really exciting that Sunshine Coast University Hospital is now commencing a publicly funded home birth program, and I think this is the best step forward to providing safe care to people that want to give birth in their homes, to have it open and have those pathways really clearly mapped out.
Yeah, I think so. I think if we as a healthcare system just recognise that there's obviously some desires and trends here, and what protocols can we develop that ensure that we can meet women's and families' desires as well as provide safe, complete care, then we're going to create the best outcome here. So new pathways, new models of care seems a reasonable choice, making sure we're ticking those boxes in regards to effectiveness and safety and other aspects. Now, this sort of brings into the question around choosing between private health if they've got the funds to do so. Obviously, there are benefits to that, as you said before, around more frequent contact potentially, but this can be more expensive. There's the cost of living crisis that's going on. So how do you sort of encourage GPs to navigate that decision-making progress around which way to go, private or public or midwife or whichever sort of GP shared care and so on?
Again, I think it's really important for GPs as that point of referral to fully understand what's on offer in their local area and then be able to speak to women early in their pregnancy or even in preconception about what is important to them and which model of care might be best placed to provide the right care for them so that referrals can be made. Public versus private, it's really important that GPs or any care providers don't make assumptions about what is best for a woman, but actually speak to her and her family about what's best for her. So while you may think that private care is out of financial reach for some people, I find it interesting that often people are very keen to rub pennies together to make things happen, basically, and vice versa. There may be people that have the financial means but are choosing public care because some of those values may be more important to them as well. And so it's always just very important to be listening to people and what values they hold close to them.
There is clearly the emerging role of different technology in whether it's models of care, in supporting women throughout the antenatal period, making it ideally more accessible and engaging. How can we leverage technology? What are the trends that you may be seeing? How are we going on that front?
It's really exciting what some of the new technology is offering in healthcare and maternity care. The use of apps in maternity care is still quite new, but it's interesting the greater accessibility that some apps are able to provide for people. So in particular, at the Mater, we have use of the Mother app, which has been developed in collaboration with CSIRO, and that allows women with gestational diabetes to be able to have their blood sugar levels viewed in real time by clinicians in the hospital remotely. So this reduces the number of visits that women need to make to a hospital, and it can allow suggestions and recommendations for intervention to happen sooner than waiting for a 2-weekly appointment, for example. There's other apps that are being used and technology that's been used to improve access to education. So women have more options for antenatal education in their pregnancy, and also remote communities or virtual communities. So parents groups or pregnancy groups that can happen over Facebook, for example, or other apps where people can connect with other people in similar situations to them.
Yeah, that's an exciting potential, isn't it? Just as we've talked about before around rural and remote care and providing best care from a medical and midwifery point of view, but providing best community care as well. We can utilise technology. Obviously, there'll be local community mothers groups and pregnancy groups, but that may not be available at that time given population density and so on. So creating virtual settings like that is a really great use of technology because that peer support component can be a real bit of magic when it happens well and supports women well. So, Kirstin, now moving back to the medical a little bit, if we consider potential complications during pregnancy, such as preeclampsia, gestational diabetes, which we've mentioned a few times now, fetal growth restriction, what are some of the early warning signs as the pregnancy progresses that healthcare professionals should be aware of, and what steps do we take?
I think I'd just like to point out that all these conditions can be quite insidious, and so emphasise again the importance of all the routine tests and investigations that we discussed earlier in the importance of early detection of these conditions. Every time a woman comes to an antenatal appointment, she should have her blood pressure checked and she should have her symphysis fundal height checked to look for the size of the baby. I would usually inquire about headaches or blurred vision and swelling, though these are all very non-specific symptoms. If a sign of gestational diabetes might be a large baby, but that's really the only sign there is. So again, the importance of that glucose tolerance test for that. And similarly, there's probably no symptoms of rhesus incompatibility. I would always tell women if they don't feel right that they should come for an assessment, whether that be with their GP or to their local hospital. And that's very non-specific, but sometimes that is all it is. They just feel weird or wrong and that can detect things. Often nothing is wrong and that's fantastic, but always to get checked out if they have any concerns. Fetal movements is something else we always inquire about and can be a sign, again, that there is something unusual going on with the pregnancy. Again, it's very non-specific, so most times everything will be fine with that.
And so can we just summarise that a little bit, because we talked about some of the important just sort of baseline examination features and processes during sort of second and third trimester, and you mentioned a number of points there, and I just want to open it up to just add anything else. So blood pressure, obviously palpation of the abdomen, symphysis fundal height, which some can review. Are there any other important parts of examination there? Fetal movements you mentioned. Any other aspects that would be routine parts?
At 36 weeks, ensuring that the baby is cephalic is important.
Mm-hmm. And so that's the medical side, but when we deep dive into those modifiable health behaviours, which we've done with our other health professionals in other episodes, which is fantastic. But what are your approach from a midwife or an obstetrician point of view around discussing preventative health practically? And it may be around their activity or their diet or sleep. Is there anything common FAQs that you would see come up and ways to approach this?
I think, like I said before, pregnancy for a lot of people might be the first time that they've really had regular interactions with healthcare professionals, especially if they've otherwise had a reasonably healthy lifestyle. So it's really opportune time for us to be able to ask questions, and often that's broached just in terms of general inquiries about their comfort, their sleep, how they feel like their appetite is, can allow small moments to put preventative healthcare in the focus of their pregnancy and their care. And for a lot of women, pregnancy becomes an incentive to improve aspects of their health. So you will often see women that may smoke reduce or be able to quit smoking during pregnancy because their priority is put on the baby. This is a time where women will often stop drinking alcohol and start looking at their diet and exercise a little bit more closely. And so it can be quite an opportune time to start looking at that on a bigger picture as well. Why would you go back to smoking if you gave up smoking during your pregnancy when actually this could provide a really lovely lifestyle for your child not to be exposed to this, or for your partner to quit smoking as well? So there's lots of opportunities to just take that narrow lens of the pregnancy and extend it out further into their wider lifestyle.
Yeah, it is an opportunity to look at, obviously we're predominantly managing the baby and the mum in this context, but to zoom out, as you say, and look at the whole person, then the whole context and the sort of familial situation as well. Now on that, what about the mental health and well-being? Because clearly that's something of significant importance in this period of life. Do you have any screening tools or strategies that are used in antenatal care to address either mental health concerns, common ones, anxiety, depression, and so on?
It is really a prominent time for it, whether it's hormonal influence or lifestyle influences and changes that are happening in pregnancy. But also mental illness can be quite irrational and just come without anything logically underpinning it. We use standardised screening tools in pregnancy. So we use the Edinburgh Postnatal Depression Scale, and ideally we would be using that 2 or 3 times during pregnancy and then again postnatally. And what that does is just allows us to standardise responses, so have a response that is comparable, and it also makes for ease in terms of referral and communication with other healthcare professionals. So when we're referring people on and we can put a number to the responses from the Edinburgh Postnatal Depression Scale, it's very clear what we're talking about, because sometimes when you're talking about mental health and mental illness, it can become more vague in terms of the terms.
So even though the Edinburgh postnatal is for postnatal depression, it's still, and it makes sense to use the same tool so you can track and see the trend over time, but that's still, it seems, an acceptable tool to use in the antenatal period.
It is fairly routinely used in the antenatal period, sometimes in the context of assessing the risk of postnatal depression, but it really is a good mood screening tool. It is quite a snapshot in time, so it refers to how you've been feeling in the last 7 days. And again, to sort of have the same tool used multiple times through the pregnancy and the postnatal period allows us to compare results and really see the progression. At the end of the day, it's just a screening tool and it has limitations, as all screening tools do. So I would say it's of more importance to be really listening to women and people, so, you know, whether that's partners or other people, about how they're feeling and how they feel that they're coping, because sometimes that isn't clearly reflected in a screening tool, but responding to how they feel that they're coping.
That's right. Checking in at every appointment and how they're going. I would just like to add that mental health assessment is part of the MBS funding for the pregnancy management fee and at the postnatal point as well.
Stay with us. We'll be right back to continue our conversation.
If your patients need help to maintain a healthy weight, improve their sleep, or better manage stress, My Health for Life can support them achieve their health goals. My Health for Life is a free lifestyle program helping Queenslanders live well and reduce their risk of developing a chronic disease. The program is delivered by qualified health professionals, empowering people with support, knowledge, and practical tools to achieve their health goals. Encourage your patients to have a free health check today at myhealthforlife.com.au and begin their journey to improved health.
And now, back to the conversation. Now, then just again widening out and zooming out a little bit more, and we're thinking about how to actively encourage partners to participate in antenatal care, especially when there's typical life and social stresses that are around and becoming potentially more of a concern going forwards. So how do you approach this aspect about engaging partners into the care?
It's a really good question. Some partners are very engaged right from the outset and they'll be attending visits. Others less so, whether they've just got other priorities. I find in delivering antenatal care, it's really good to have a combination of visits where the partner's present, but also when they're not, because that allows us to do further psychosocial screening on risks of DV and control in the home as well. But it is great when partners come, and I like to look at their role in supporting their pregnant partner through the pregnancy or the birth. We've sort of evolved as in our society and our culture that there's an expectation that the partner is the primary support person during birth, but sometimes we lack in giving them real useful tools that they can use during that time to support. So there's always the opportunity to talk to them about what their actual role is. That extends through the whole continuum of pregnancy, birth and early parenting. As partners have become more involved in particularly early parenting, there's an instinct to remove some of those roles away from the birthing parent. But sometimes in relation to breastfeeding, we really want to preserve that relationship that the mother and baby have and allow the non-birthing parent to take on a more supportive role, still bond with their baby without feeling that they have to feed the baby in order to bond. Kirstin was telling me just yesterday about an online gaming group for non-birthing parents, which was a really nice way to view support for the non-birthing parent. There's also some dad-specific antenatal classes. I know there's some in Brisbane and there's some in regional centres. One of the things I've noticed with these is that they often put them in the context of a pub, so beers and babies or antenatal classes at the pub, and that is seen to improve engagement, but I think that can also be somewhat problematic and stereotypical in itself, that men particularly won't engage unless there's beer involved, which simply isn't true.
What are some of these programs that you've come across, Kirstin?
Oh, I heard it on the ABC radio. The president was talking, I think it wasn't online, I think they were meeting in person, having dad's gaming sessions, which sounded really fun and really, really great because it's going to allow men to get together who may not enjoy other forms of activities. So.
I think it's really important just on this note that we extend the non-birthing parent out to people that may not identify as men as well. We're seeing growing numbers of families that are made up in all sorts of different ways, and sometimes the non-birthing parent, if they don't identify as a man, may feel excluded from some of these dad-specific groups, and so we need to find space where everybody is included.
It's interesting phenomena when we talk about the change in the role of the non-birthing parent over the last, say, 60, 70 years, where it was very much traditionally a women's only and or doctor/midwife only situation with the mother, the birthing mother, and then slowly men have sort of been invited more into this circle. And I've got 3 kids, and it still feels like we're still a little bit lost as to what role that is, outside being a very stressful, anxiety-producing area where you don't have a lot of control. But certainly opening up this conversation, developing more community-based or peer support or just other resources to sort of normalise and just have this conversation is going to be a healthy thing going forwards.
Yeah, I want to point out that being a support person in birth is really hard. Like, no shade on the women who are actually giving birth, but that role as a support person, like you say, it can feel like you really don't have a lot of control. And often in relationships, your role has been to protect and save your partner from challenging situations. And so birth may be one of the few times that your role is simply to support without protection. I usually use the analogy of it's like running a marathon or doing any sort of endurance sport where if your partner's on the sideline, you don't want them to pull you out of the race because you're red and sweaty and in discomfort. You want them to cheer you on and see the strength that they see in you that you may have forgotten that you've still had. And so as a support person, you often have to change your mindset a little bit to support rather than protect.
Yeah, that's a very important point. Thank you. And 2 other aspects here around, one being trauma-informed care and how we approach people who may have experienced trauma in their lives and how that may impact their engagement with the healthcare service. So what's the emerging approaches to this?
It's a really topical point at the moment, and we are learning a lot more about traumatic outcomes from birth versus positive outcomes and trying to implement preventative strategies. So part of that is doing education with all of our staff around trauma-informed care and what we refer to as universal precautions. So we should be treating everybody as though they have trauma in their history, whether that's birth trauma, sexual assault, physical assault, anything that they find traumatic. But we should be treating everybody as though they have that history. And that might mean just as simply as taking things quite slowly, speaking to them about what the recommendations are for procedures, and then being very specific about the consent that we gain from them to do. In maternity care particularly, we're doing a lot of intimate procedures, and they might be procedures that we're very comfortable with because we do all the time, but for a lot of the people that we're delivering care to, they don't take their pants off in front of people every day. And so really kind of keeping that at the core of those procedures, that we're taking it very slowly, explaining what the expectations will be, what they can expect to experience from that procedure, and that their consent is important to us and can be withdrawn at any time as well.
Kirstin, is this something you've come across a bit? And in particular, what I'm wondering is, it's a really big area and we can't provide training on trauma-informed care over the podcast. So a good starting point is at least a sort of screening question, or at least opening up the conversation. So how would you broach this early in a consult? Would you ask directly, are there any experiences of trauma that you think may be relevant to your care going forwards, or how do we actually broach this as a topic to bring up?
I start with sort of a broad question, like, how do you feel about your last birth? or was there anything that was particularly concerning, anything you wanted to discuss? Sometimes I'll ask, did you have any traumatic experiences, and let it open up from there. It's also then about asking again about what their wishes are for this. Do they have any particular concerns that they want me to know about? Sometimes you'll meet people during their antenatal care and have plenty of time to go through this and discuss things. Often, especially in the public system, you'll be meeting that person for the first time when they're in labour. So I think always giving the perception that you have time and patience and are willing to listen is really important.
Yeah, asking open questions. So when you're reviewing a previous birth, we often have access to records, but a woman's experience of that birth may be very different to the objective details that we can get in a report. And so you may have those facts about the previous birth in the back of your mind, but asking her how she experienced it may shed greater light onto it.
And this has raised the importance of GPs in particular, because we're typically the first point of call for a lot of these, obviously, pregnancies, and then, as we said, it'll refer off accordingly. But we have a very important role in that, those early parts of care in particular, and of course across pregnancy. But bringing it up as we would almost any consult, where past medical history, past mental health history, past birthing history, and then being curious around that experience, and just having those open-ended questions, and then to the sort of ideas, concerns, and expectations around pregnancy, just opening up that question. It's likely with those open-ended questions that the truth will come out, as it were, anyway. And as the pregnancy and relationship develops, then we can get a little bit deeper if we need to, if we suspect that there's something else going on here. And often there can be clues, can't there, around the way people have they want their pregnancy to go a certain way, and that may be informed by past experiences, and then that will give us the clues to delve a little bit further. And then that, again, brings us to different cultural backgrounds, and people of different cultural backgrounds, and First Nations peoples, and how they may have different beliefs and practices and approaches during antenatal care. It's obviously a potentially very sacred time of a person's life. And so what's your advice around how we perhaps ensure our advice is sensitive and tailored to individual needs?
I think, once again, it's really important that we ask women, or ask people what values are important to them, and particularly not to draw assumptions about the influences of a person's culture on the values that are important to them during this time. I've worked in the past with cohorts of refugee women in Brisbane, and a good example of this is Muslim women wearing a hijab. It's quite a visual cue that they have a set of beliefs, but when you actually start to ask women more specifically about what's important to them, surprise, surprise, you find women have very open and different views. And so an example was I started asking women who wore a hijab what they wanted to do during birth if their hijab came off. And some women, it was very important to them that I could help them replace their head covering. Other women were like, you're giving birth, what does it matter? And other people, it was more dependent on who was in the room at the time, whether their heads were covered. And so holding that space quite sacred and close for them, making sure people knocked at the door before coming in to allow people to make adjustments if they needed to. And I think this is particularly prominent when it comes to First Nations people, that we don't prescribe what's important to them, but we ask them what they need and what's important to them.
So as you say, recognising the cultural norms, practices and influences that may be present, but also not assuming that they are present, and always being curious into personalising those still.
Absolutely. I mean, we work in a Catholic-based hospital, but you could not assume that because somebody marks themselves as Christian on their paperwork that they come with a preordained set of beliefs that follow that package. They're made up of a whole lot of different influences, and the only way we're going to find out about them is asking.
That's absolutely right. There are so many cultures in the melting pot that is Australia that I don't think you can expect to know every single culture. So all you can do is ask.
Be humble and curious.
Yeah,
that's right.
Absolutely.
Let them define.
Yeah. Excellent. Are there any good resources on this front, especially for First Nations Australias? So are there, the Queensland Clinical Guides, I imagine, support from a medical point of view, that side of things, but are there any go-tos that you would recommend for health professionals?
I've read some good books in the past, but actually going to the people is really the best resource I can think of. So whether that's the client or patient themselves, keeping in mind when we're talking about First Nations people, we've got generational trauma as well that can be related to healthcare and institutions. So sometimes the individual may not even identify what the triggers and the sources of trauma are. Sometimes it's really important to be going to the elders in the community and understanding. Also with First Nations people, we've got so many different cultures in Australia. It's not one homogenised culture. And so understanding the values of the people that are local to you, but then understanding each individual within that culture as well.
And finally, what are the top 3 things you wish every woman knew as they entered pregnancy? Kirstin, let's start with you.
They need to take folate before they get pregnant and for at least the first trimester.
Mm-hmm.
So I guess that ties in with preconception care, doesn't it? So being your best healthy self before getting pregnant if you've got the option.
Mm-hmm.
Go and see your doctor early, I think is really important, so they can start you being informed on what care you need from there and potentially refer you on to the hospital sooner rather than later.
Mm-hmm.
And my last point is about, as a patient, they have choice and they have a voice, and they need to stand up for themselves and tell the health professionals what it is that they want throughout their pregnancy and not just be passive.
And we as health professionals can remind them of that you have rights. Please do tell me if there are things in the direction you'd like them to go or you're not comfortable with something. And of course, there's always a genuine compromise of agendas there, but you can't fix that unless you know what those intentions are.
Absolutely. We can't hold people's values at the centre of our care if we don't know what those values are. So to piggyback off that point, I think people need to be really informed of healthcare options and maternity care options so that they can choose a model of care that really fits their needs as best they can. And the other big point that I would want to make sure people are aware of is that this is a really big deal. Having a baby every single time is a huge transition that happens in your life, and to some extent you have to be completely broken down as a person to be rebuilt as a parent. And so this idea of matrescence and becoming a mother needs to be respected, and people often go into pregnancy being very aware of that they're going to be tired and they're going to lose some of the autonomy in their normal lives and it's going to be hard work, but sometimes they don't realise how much love they're going to feel and how their heart will just explode with love for this child. And Kirstin and I both have older children, and so I think we can say from a point of experience that there's a lot of fun ahead.
There's that initial investment, but it does pay off.
Yeah.
All right. Well, thank you both for your time and expertise and insights and experiences today. It's been wonderful to have you both on. Thank you.
Thank you.
You're welcome. Thank you.
Today, we've been talking to Dr. Kirstin Millard and Kieran Froese about antenatal healthcare. For more information on today's topic, visit the Health and Wellbeing Queensland website at www.hw.qld.gov.au. If you've liked today's conversation, be sure to subscribe for future episode updates. We'll see you next time on the Clinician's Guide to the First 2,000 Days.